Good evening. Good morning. I'm Steve Lowis. I'm a Paediatric Neuro-oncologist from Bristol. Thank you very much for inviting me. And thank you to Bruce for laying the scene for everything that I want to say. So you're going to make it much easier for me to talk about what I want to talk about. There's a lot of good news in brain tumours. That may seem a bit of an oxymoron, but the last few years have seen an explosion in developments in molecular biology and in treatment, and I want to give you some of that good news now. But one of the things which you'll hear about this afternoon is the work that Sophie Long has been doing on the head start study. Early diagnosis is really important. I'll also talk to you a little bit more about better understanding of how brain tumours develop and the way that gives rise to new targets and to new therapies. And then a little bit about technological advancement that have come in recent years. And one particular example I'll give you, which is, I think, offering a significant possibility of improvement for one particular brain tumour. As Ruth said, it's stratification which really makes a difference to how we treat people. So we want to make sure we give the right treatment to the right patient. We don't want to give too much to the good players, we don't want to give too little to the bad players. And that's a really important understanding for all treatments that we have. This is on the way to producing an individualised therapy for our patients, and we're really getting close to a situation where that really is a possibility. And of course this is going to translate into improved survival, I have no doubt. The bad news, in brain tumours in particular, is that the after effects of brain tumours and also the after effects of the treatment, particularly radiotherapy, can be really severe. So many children have lots of neurological disabilities. There's an effect on IQ, there's an effect on physical abilities. And they have a really significant complication, an effect on education, on people's ability to get jobs in the future, having families, living independently. So we have to look at any advance with also an eye on what the future holds for all our patients. And we have to look at quality of life. We spent a lot of time over the last decade looking at quality of life, and I think the next phase for things that we have to do in our clinical trials is look to see how we can intervene to improve rehabilitation after people have had brain tumours. And that means we identify the problem, we recognise where people have disabilities or other problems, and then we identify how to intervene, and that might be with physiotherapy or occupational therapy, it might be with psychology or education. The important thing is that this is done in a systematic manner, and we start doing this right from day one. And we continue for as long as people need it, which for many people will be forever. I'll just take a slight aside to advertise a particularly useful tool, which I think everybody in the room could make use of. This is called My Quality, which is a quality of life tool. This is a tool that anybody can go along and put in what you think is the most important thing for you whilst you're on treatment. And you can make an assessment of your quality of life by those criteria. So this is not someone else saying, can you go to the shops, and that's an important parameter. It's the thing that's important for you. I would strongly recommend that we as physicians use it, but that everyone else considers using it for yourselves. Okay, back to the good news. Early diagnosis. Head Start, fantastic campaign. I'm not going to spoil Sophie's story because it's a really successful thing which deserves to be done properly. Better understanding of how brain tumours develop. I'm going to talk about just two types of tumour because we don't have time for lots. I'm going to talk about astrocytomas and medulloblastomas. Those are the two most common tumours in childhood. The tumour that I'm picking here is a hypothalamic astrocytoma. This is a, quote, benign tumour. If you look at that brain tumour, you can see that there's nothing benign about that. It's characteristics of local destruction rather than spreading around the body, and for that reason people tend to refer them as benign. People survive from these tumours very well. You can see that survival curve, which is the same as the one that Bruce showed for different tumours, is predominantly at the top. So about 80% of people will survive from the hypothalamic astrocytoma. But what that doesn't tell you is that about 62% or thereabouts of patients will have recurrences and recurrences and recurrences. So very few people will get through the end of 10 years without having had multiple operations, lots of occasions when the tumour starts to grow again, lots of different chemotherapy cycles, surgery, radiotherapy, and the result of that is that they end up with very significant disabilities. The morbidity of that is enormous. And what we need really is to identify who are those patients who are going to need lots of treatment like that, can we intensify it, and who are the patients who perhaps we can get away with giving less. So what we know is that these tumours are driven by one of these pathways that was beautifully shown before. The MAP kinase pathway is well recognised as being a cause of low-grade astrocytoma. If you have a condition called neurofibromatosis, then this gene here, neurofibromin, is blocked. And what that leads to is an activity of another gene called RAS, and that leads to cell proliferation. So people who have neurofibromatosis are prone to developing tumours spontaneously. What can also happen in patients who have benign brain tumours, low-grade astrocytomas, just because of bad luck, is you can get a mutation of other genes, and this one is called RAF, and that can be locked in the on position, and that can directly lead to cell proliferation as well. So we know that RAF is a very important gene causing low-grade astrocytoma. And in fact, if you identify RAS as a cause of your tumour, we know that this is an important prognostic factor. So again, we can stratify. We can look to patients who have got a good, relatively good, or bad outcome based on whether they have a genetic mutation or not. This is a really important tool that means that we can make a decision about how we treat people in the future. So we can look at the patients who have different strategies for treatment, and hopefully in time we can start looking for targets for therapy. So there are 4 trials opening up now which are specifically identifying this pathway using non-chemotherapy drugs. So drugs that you wouldn't normally regard as being conventional chemotherapy, they're inhibiting these enzymes, blocking the pathway, and hopefully causing responses to these tumours. So that's an example of how stratification and understanding how a tumour is developing can give you further insight. Here's another example. So this is medulloblastoma. Medulloblastoma is a high-grade malignant tumour. It affects the bottom half of the brain called the cerebellum. And on the left-hand side is a patient who's got a lump right in the middle of the cerebellum. On the right is a patient who has a lump, and they have numerous clots all around the brain, and those are metastases. This is the main problem of medulloblastoma. Over the years, we've had an improvement in overall survival for people who've had medulloblastoma, and these are successive cohorts rather similar to the one you've seen previously. And those improvements were marginal, but what's been very good is that the most recent study, PNET4 study, which is an international collaboration, has shown a very significant improvement in outcome because of systematic treatment, and this in the context of reducing the amount of radiotherapy that we're doing. So we made a very significant improvement, and that's great. But that's not the whole story. Over the past 5 years, it's been very clear that actually we're not dealing with medulloblastoma of one type. We're in fact dealing with a number of different diseases, all of which we've been calling medulloblastoma. The first 2 that were identified were driven by 2 separate pathways. One's called Wnt and one's called sonic hedgehog. Sonic hedgehog, by the way, if you identify a gene, you get to call the pathways and call it what you want, and so because all these guys are such nerds, they all play computer games all the time, they call it sonic hedgehog. So Wnt and hedgehog pathways are driving 2 particular types of medulloblastoma. And that's an important consideration. It also incidentally means that they arise in different parts of the brain. When you look deeper and you're using more sophisticated techniques, in fact it's been possible to identify at least 4 types of medulloblastoma. Wnt and sonic hedgehog, and then people ran out of names, so they called it group 3 and group 4. Now why does that matter? Well, one of the things is that these tumours arise at different ages. So what you see, for example, is that the Wnt pathway is more common in older children. The sonic hedgehog pathway is very common in infants and very common in adults. If you not that it's very common, but it's more frequent in adults. Group 3 is more common in young children, and group 4 is common in older children. Why does that matter? Well, it matters because of this. If you look at the overall survival of children who've got each of these different types of tumour, you can see that they're chalk and cheese. The Wnt pathway tumours is perhaps the most striking. With conventional therapy of Wnt tumours, almost nobody dies. You have a nearly 100% likelihood of being cured from your medulloblastoma by conventional treatment. That's fantastic. You know you've got a Wnt tumour, you want to know that. What it also means is that we're probably giving too much therapy to these patients, and actually we could afford to pull back. We know that the main complication of children who have medulloblastoma in childhood is the neurodevelopmental damage that we cause by giving radiotherapy. So if we can pull back and give less radiotherapy, then we have a real chance of improving their outcome. The second graph shows you what happens in infants. So an infant brain is very, very susceptible to damage. If you give radiotherapy to a baby of 3 or 4, child of 3 or 4, then you will cause very profound disability. So if we can get away without giving radiotherapy, then that's what we should try and think about. And the group where we might concentrate that is the sonic hedgehog pathway-driven group. So we have a possibility for stratification. We might reduce late effects, and actually we may also have new therapeutic targets. So LDE225 specifically targets the sonic hedgehog pathway. So we may again be able to treat these tumours without ever intervening with normal chemotherapy ultimately. And this is a clinical trial which is currently open. Okay, new techniques. This is the end, coming towards the end. Very rarely in your professional life do you really feel humbled by people's abilities. And I have to say that some of my colleagues in Bristol have done things which, it's akin to Star Trek, actually, the stuff they're doing. And I want to share it with you because I'm just so excited by this. I'm going to talk to you about this tumour, which is a diffuse intrinsic pontine astrocytoma. Okay, these are horrible tumours. The survival for these children is nearly zero. You can see there's no line along it, it's all on the bottom. So children manage to live for about 9 months before they die. If you give radiotherapy, you might improve the survival by 3 months. This is a truly awful tumour. It's a high-grade astrocytoma. Bruce alluded to that at the end of his last talk, of the midbrain of the pons in the middle, and you can't take it out surgically because that is such an inaccessible part of the brain. My colleagues in Bristol have developed this system where in patients with an unrelated condition, Parkinson's disease, they've been infusing therapies straight into the brain tissue. They've been using microcatheters going straight into the deep parts of the brain and infusing for over a year at times with these various catheters like this. This is an ideal situation for replicating in the context of an inaccessible tumour. So they've developed a robot which will allow you to accurately implant microcatheters which are a diameter which is less than a millimetre across. The accuracy is within 0.3 of a millimetre at the end of the needle. So the catheter is, the robot is used to implant the catheter, and catheters are inserted manually, and then these are brought together into this little thing here, which is a sort of micro port. Some of you may know what are portacatheters for delivering a chemotherapy into the blood vessels. Well, this is an equivalent of delivering chemotherapy directly into the brain. And this is an example of how the system might be set up, where you have a number of different lumens for these going into specific catheters, which then go into the brain. And different catheters can go to different ports. All of this is done on a fairly tiny scale. This is an example of the first patient in Europe ever treated with this treatment. A patient of mine who had a brainstem glioma. And the red area is the volume of infusion that we were able to achieve for this young man. This is another patient who had an anaplastic astrocytoma, so this was an adult patient in fact, who had a very extensive tumour which essentially was outlined by the blue area. Chemotherapy was instilled by 4 separate ports and managed to deliver chemotherapy to that area. This patient had an absolutely astonishing response to treatment. We treated 5 patients in Bristol so far. These patients have not been made worse by the treatment. One patient has made a remarkable recovery, the other patients have succumbed to their disease. The point being that this is a potential change where no change has been before. And we're now hoping to start a clinical trial as soon as we can get the funding, whereby we're giving infusions of chemotherapy in patients just after diagnosis for the first 3 to 4 months. So, just to summarise, what we're interested in here today is everything that we've talked about already, which is identifying good risk groups and bad risk groups, individualising therapy, and where possible to take advantage of any improvements in technology which made significant advances. Thank you.
I think we could take one burning question for Steve before we move on to leukemia, if anyone has one. It's astonishing technology. But as you can imagine, this sort of research is expensive, and I'm sure Steve could give us an estimate of how much money he needs to get that trial